I am Dr. Sita Rajan Kumar. I am a senior consultant at Columbia Hospital, Whitefield in Bangalore. The world over, for the last decade and a half, the incidence of the cesarean section has been alarmingly high, and more than the world over, it was particularly in our country. Hence, the recent government trend to try and curtail this to keep it at a sensible low level. The recommended level is it should not be more than 20 to 30%. Unfortunately, in our country, it had soared to almost above 60 to 70%. The government is trying to curtail this, but it may not be completely effective because there are various issues involved in the incidence of cesarean section. In our country, we have patients who come in, of course not in the very urban areas, but in the rural area with prolonged labor, obstructed labor, where the incidence of cesarean obviously will increase. So, there are patient issues as well as the doctor's issues. The patient issues in the urban healthcare has been unfortunately where patients do not want to undergo the pain, the trauma and the trial of a normal delivery, and hence they insist on a cesarean section. It is our duty and it continues to remain our strive to make sure that we try and convince them to try for a normal delivery as far as possible. In high risk pregnancies, which now unfortunately is increasing due to various factors, maternal age, other diseases which come in by the maternal age going up like hypertension, diabetes, all of these with their own complications again add to the incidence of the cesarean section going up. Apart from this, we have the fetal problems as well, where inactivity, diabetes, babies becoming too big, hence again the reason for the cesarean sections going up. But overall, we try our best as far as possible to keep it at the minimum, trying to manage with whatever wherewithal we have in the urban as well as in the rural sections to make sure that we keep it to a not a very dismally low level, but at least an acceptable level. It was in our textbooks taught to us far earlier that once a cesarean can be tried for a normal delivery, twice a cesarean has to be a repeat cesarean. In today's scenario, most people going in for just 2 children, the latter part, which is 2 previous cesareans going in for a cesarean again, does not feature very often. The normal delivery after a cesarean requires a lot of skill, competence and more than anything else, the infrastructure to provide for the risks which are included in trying for a normal delivery after a cesarean. In a hospital setup where we have all the recommended backing, that is the pediatrician, anesthetist, blood bank, ICU, all of these are actually mandatory to be able to try for a vaginal delivery after a cesarean. It also depends on what the cesarean was done for the previous time, whether the same indication repeats, and obviously therefore we are reluctant to try. But otherwise, we make every effort to try for a normal delivery after explaining the very small risks which are involved in doing so. The patient has to be taken into confidence, their consent is taken that they are aware of the risks of trying for a normal delivery, and more often than not, if there is a judicious choice of patient for trial, we get away with it more than 90 to 95% of the times trying to achieve it and successfully achieving a normal delivery. Columbia Asia is different in the sense, number one, we give all our antenatal patients a very thorough checkup as far as possible. Nothing is missed in the recent whatever are the normal indications, whatever are the normal tests to be done, whatever are the normal guidelines to be followed, they are very strictly followed. So, as far as possible we are trying to eliminate any surprise which comes up suddenly. Then when they come in labor, they are very well prepared with their exercise program, they are told what should be done, what should not be done, they are encouraged to be active whatever is their job, physically active right up until the last minute till they go into labor. In fact, I even tell patients that they should not apply for their maternity leave beforehand, because being active goes a long way to having an easy delivery and managing the stress of looking after a newborn after the delivery. Apart from that, we have a very good backup in the form of our neonatal setups. The pediatricians, the neonatologists are very well equipped, and the technology which is required in the form of ventilators, high-end ventilators and all the monitoring which is required is very easily done for these babies. That is why we are able to get away with even very low birth weight babies, which is less than 1 kilo. In fact, our record is we have managed to make a baby of 650 grams survive, and the child is doing very well. The high risk pregnancies unfortunately are going up. In fact, we hardly ever see a normal, completely normal pregnancy right until delivery. One of the factors which is deciding this is the maternal age, people putting their career before their marital status, then before their maternal status, and therefore the older they come in, number one, obesity which has added on by then, chances of diabetes. Unfortunately, our incidence of diabetes in pregnancy is almost as high as 50 to 60%. Added to that, the obesity which allows for hypertension, thyroid problems becoming very common, almost 35 to 40% in our last statistics which we had done. Apart from these, pregnancy losses which have happened due to various reasons, loss of children, loss of the fetus even before they have been born. And then of course, we have the other rarer problems like I have dealt with renal transplants in pregnancy, connective tissue disorders. All of these are a completely different spectrum of diseases which have to be taken care of and are well taken care of, because we have a team approach. The physician, the surgeon, the immunologist, everybody is involved when we take care of a high risk pregnancy. It is a challenge to the doctor, but it is a rewarding challenge more often than not. The sex detection and therefore choosing the sex of the child is going to be completely obsolete. One, of course, the government has a very, very effective policy in place, and therefore that would deter it, but the mental makeup and the change in the general population accepting a girl as much as a male child is going to be very, very helpful. The next thing, of course, more people working, therefore more empowerment, availability of information, availability of sharing experiences, and therefore making them more confident, more careful about their own health, putting their own health as much as their own child's health or the family's health. Therefore, we are going to, at least across the spectrum, improve women's health in India as well as internationally. The third thing is we still are battling with certain problems which come up in the obstetric career of the woman. We hope that there will be further advancements in biochemical markers, radiological markers, and therefore we continue to maintain as good fetal outcome as well as a maternal outcome.